Well, thank you very much indeed. I mean, really, thank you. And it is genuinely, I say this, it is an honour to be invited to give this talk, and it's a privilege. But it's also been a real pleasure already to witness the presentation, actually, of these awards. And I know what hard work goes into all of that. And I just want to say, whilst there are so many obviously excellent young doctors around, maybe somebody could just look at my knee a bit later. And the guy who deals with pain, please. I'm going to talk. I am going to range over quite a lot of things, and some of it I'll go over quite rapidly. But we can maybe talk a little bit later. But what I want to do, if I'll just briefly tell you what I'm going to talk about. One is to just to note and to think about some of the ethical dilemmas that we might be concerned with, why and how they seem to be increasingly visible. Think about some of the principles and values that we do bring to bear on these issues when we think about them at whatever level. Talk about some of the work that the Nuffield Council has done in these areas, and work that we try to very much to gear towards policy and practice, rather than simply being at a relatively high level, and then to add some concluding remarks, which are really some general thoughts on my part, rather than pretty hard conclusions. But first, I should just say a little bit about myself. I mean, you've heard a little amount, but you know, why on earth am I here? I often ask myself that question. My background in this goes back actually. About 25 years ago, I joined the Department of Health, and I did work on childcare legislation. I went out to the Human Fertilisation and Embryology Authority when it was first set up, and I was there for a number of years dealing with some of the early issues around IVF, embryo research, gamete donation. I spent a few years in the European Commission in Brussels, where we were funding research in bioethics, putting together, where we were encouraging people to come together in multidisciplinary teams, scientists, medics, social scientists, philosophers, lawyers, etc., from across Europe, and trying to invest in bioethics research at an early stage. I was then back to the Department of Health doing work on human tissue legislation, but also the transplantation policy, bereavement, and a lot of this was the fallout from the Bristol and Alderhay reports and the organ retention issues. And then I've been for the last 5 years or so at the Nuffield Council on bioethics. And certainly what we do here, and what in a way characterises what I've done all through, is to try to, we stand at that point where different disciplines meet, whether they are medical or scientific, social science and others, and try to understand those different languages and provide the bridges between academia and policy arenas, and also bring them into more practical areas. And of course, one of the things that we need to do there is to ensure that we find a common language, common ways of understanding, things that we do need to be meaningful at all levels and to all people. And this is not easy. It is frequently not easy. When I was working in Brussels, we were trying to encourage groups to come together to join this multidisciplinary effort, and to bring their academic work to bear on really practical day-to-day problems. And I went and presented this to a meeting as a group of geneticists and philosophers in Cambridge who were, and I was hoping to interest them in joining this and presenting the idea that we can bring their work to practical effect. And they were all nodding, and it was all going very well, and I thought, yes, we've got them going. And then as the meeting went on and things started to drift, I realised that we hadn't quite got there when one of the philosophers just pulled in and said, just a minute. First we have to distinguish the epistemology from the metaphysics. And I just think that, you know, that's the kind of language that it's necessary for the long-term philosophy, but it's not quite what we're doing necessarily with the practical bioethics. Anyway, that's just a little bit of the background of what brought me to this kind of place. The kind of stuff that we deal with, or that you deal with, or that is problematic. These are the kind of things that we might think about. There are many of them. It's just a selection. Genetic testing, where for example, one member of a family may have a result that they don't want to disclose to other members of the family. Tests that are available directly to the public as consumers, where the information is shall we say, dubious even, and not mediated by any expert view. In dementia, many day-to-day issues, in fact, that may be around whether to use electronic tags on people who may get lost, whether to use restraint on people who may get hurt, whether to tell the truth to somebody who asks every day where his wife is when she died 5 years ago. There are many issues that arise in this kind of context. We'll touch on some of these later. Issues at the beginning and end of life, I think we know the problems around there. In research, we've got a project starting quite soon on issues around children and research, the circumstances in which we need to protect children on the one hand, but at the same time make sure we develop a medical practice that is adapted to children. Telemedicine, whether remote monitoring or remote monitoring of compliance with medicines is appropriate, or whether we lose something in the loss of contact day to day with patients. Questions around lifestyle issues, how do we intervene in cases of, for example, obesity in what are essentially lifestyle rather than medical solutions. New technologies in neuroscience. We have another project running at the moment looking at interventions directly into the brain, deep brain stimulation that might reduce involuntary movements in people with Parkinson's disease, but might also induce changes in behavior, in personality. So there are many ways in which these problems seem to occur, and they seem to become increasingly visible. And the question is that because they are increasingly problematic, or is there something else to it? And I don't know that we can answer any specific questions here, but it's interesting that it's not just in medicine and healthcare that these things are surfacing. So we see in retail, we now start to become very familiar with ethical trading, with fair trade that's now very well established. Although what it means to be a fair trade constituency, as Batley and Spen claims to be, I'm not entirely sure. But we've become quite familiar with this in all kinds of ways. In business, we hear about corporate social responsibility frequently. Martin, I discovered a deadly safety flaw in our product. Who should I inform? Well, no one. The stock would plunge, we'd have massive layoffs, your career would be ruined, but my negligence could cause the death of a dozen customers. Oh, the first dozen is always the hardest. And we can characterize business in this way, if you like, and see that business is in a way trying to claw its way out of that caricature. But it's not actually that many years if we go back in the history of medicine that we find some things that are equally problematic. And I turn to the US here to look at the research in Guatemala in the 1940s where people were deliberately infected with sexually transmitted infections. And then the Tuskegee experiments that ran into the 1970s before they were stopped, where for 25 years after the discovery that penicillin was effective as a cure for syphilis, men were still not being given treatment, quite deliberately. This was black men in the south of the United States. So this is going into the 1970s. Even in banking, the ethics of banking, conclusions from the financial crisis. We now, we need to hear, we're making demands on this. I found this on Amazon. I was almost tempted until I found it was $139. I did really laugh out loud. In football even, what I find really fascinating about this picture is that he's obviously so used to it, it doesn't even grimace. It's just like it's an everyday bit action. And just, excuse me, in the interests of fairness, as an Arsenal player and a Chelsea player as well, and in football, I mean, it's quite interesting because we can talk about fairness, and indeed we do, whether it is fair to induce that kind of foul or even disciplinary action. But football has been talking about respect for quite a little while now. They've got a long-standing campaign drawing on the notion of respect. Even the Football Association recently published a code of conduct for its England international players. Well, I went online and looked for that and I couldn't find it. But I did find a code of conduct for all adult football players. I found a code of conduct for all junior football players, a code of conduct for officials, and even a code of conduct for supporters. which I didn't read, but I'm not quite sure to what extent they're going to have any influence there. But the point is that it's not just in healthcare, it's in healthcare and elsewhere that we see issues that are problematic and we appeal to experts, we appeal to principles, we look for guidelines, we look for policies that can support the practices so that we can have a little bit more confidence in our decision making. So in some ways it is new, it is becoming more visible, it's not entirely new. This is Otto van Veen from 1600, a painting of Julius Caesar consulting the oracle. So consulting, seeking the wisdom of the oracle. The oracle in this case is the oracle of the holy chickens, curiously. I would like to think that your ethics advisors are just about as wise as some holy chickens, at least. In medicine, we kind of thought we'd worked it out to some degree. Beecham and Childress, I mean, very importantly, proposed this framework of 4 principles: autonomy, beneficence, non-maleficence, and justice. They become actually very familiar to many people working in medicine and healthcare, and they have been really a very important mainstay of medical ethics in recent years. And so it's not to diminish that or not to in any way reduce its importance, to say that actually I think it's turned out to be a little bit more complex than simply working with those 4 principles. I think what started to become clear, and there are other people here who are much more knowledgeable and expert about this than I am, is that Beecham and Childress to some extent was based on an individualist notion of ethics, where that is situated largely within the relationship between the individual clinician and the individual patient. That's not entirely the case, but this is just very rapidly. And this doesn't bite quite so well in other areas where, for example, we have issues around public health, where there may be interventions that are not imposing or proposing to an individual, but to a whole population. It's less easy to see how to work it in the context of incapacitated individuals, whether they're adults or children in research contexts. And then we have whole new paradigms around preventive and predictive medicine, not to mention areas where healthcare is working very closely with social care, and you have potentially a whole new different set of environments and issues. And then we have clearly new technologies that challenge us in other ways as well. But there's another dimension to this, I think, which is part the reason why some of these issues are emerging more forcefully now than they may have done in the past. And this is about, I think, a cultural shift where there is a greater demand for transparency. I think actually we made good, by and large, we make good ethical decisions. We all do in our private lives, in our professional lives, and we're challenged to do these things all the time. I think we make good decisions. But more often than not, we do them privately. And we don't necessarily expose ourselves to all of the thinking that's gone on in making those decisions. And I think that when we're making decisions now in a public context that have an ethical dimension, we are quite rightly challenged to show publicly the reasoning. And so I think that this is just part of a backdrop in all areas where we need to demonstrate transparently how and why we arrive at the kind of decisions that we do. So, if we've got a more complex environment and Beecham and Childress doesn't quite do the whole job for us, we then need to look at, well, what else is going to help us here? And I was involved when we were funding bioethics research from the European Commission. There was one very nice project that was led by a philosopher from Copenhagen, and he'd got a dozen partners from different parts of Europe in law, philosophy, medicine, science, and all sorts of areas. And this was working through, it was called Basic Principles in Bioethics and Biolaw. And it culminated in a big meeting in Barcelona at which they set down their set of principles that was going to help. And this was known as the Barcelona Declaration. And just so that I didn't get it wrong, this is just a little aside, just so that I didn't get it wrong, I Googled the Barcelona Declaration to make sure I got the right principles, and I found a dozen Barcelona Declarations. It's incredible. there must be something about Barcelona that just kind of brings people together. So there are all these consensus. My favourite one is the Barcelona Declaration of Wineries for Climate Protection. I wish I'd been there. But the Barcelona Declaration that I was looking for was this one. And it proposed that clustering this thinking around autonomy, dignity, integrity, and vulnerability. And there are 2 fat books that talk about it, but you can see in some ways how some of these principles now can bear upon some of those other more complex issues that we'd started to think about. So, can we take our set of principles, feed it into the machine, and deliver our easy answers? And the answer, of course, is no, we can't. It just isn't going to work like that. First, still, we're working with a set of relatively high-level principles that don't really bite when you get to them at a practical level. At least it needs a further elaboration. It needs to be brought down into a more practical arena. So that kind of framework is rarely going to give us a definitive answer in a particular case or in a particular type of situation. What's more, they're not going to remove the need, and nor should they, for judgment still to be exercised. So we still need to apply that judgment to take the situation, consider the facts, consider the evidence, balance the kind of principles that are at stake, and then in a proportionate way arrive at a considered judgment. So our high-level principles and frameworks can only assist in that process. It doesn't remove the responsibility for doing it, but that's what we want them to do. What's more, we've seen 2 sets of 4 principles. Well, I can show you bigger sets. The Bioethics Convention of the Council of Europe, which sets out whole frameworks that can be applied in all sorts of different circumstances. It's been signed up to by many countries across Europe, not just the EU, but wider Europe. Not the UK, interestingly. The UK hasn't signed or ratified this convention. But if you look at the introductory text and the first couple of articles of the convention, we see these principles listed as relevant: respect, dignity, benefit and welfare, rights and freedoms, equal access, etc. Of course, these then get elaborated into particular situations. And by the way, I should just say that I am totally mixing up the notion of principles with virtues and with values. If there are any philosophers here, I'll be shot down. This is, they are different things, but I'm mixing them all up. In one sense, the distinctions are quite fine. They're quite difficult to tease them apart. These things overlap, but in any case, we kind of know what we're talking about. These are relatively high-level notions that support the way that we think and approach these questions. If I then go back as well over the Nuffield Council's reports over the last 5 years and see what principles or values or virtues we've called on there in our work, you see an even longer list. So now we have, faced with any particular problem or any particular situation, so many possible ways of approaching it that, frankly, I don't honestly know how one can, how I can ask anybody to do that. So this takes us on to say, well, how are we going to make this work? How do we make this actually more meaningful? And so I would just like to talk about how we do this as the Nuffield Council. And the first part I should say is about the process. This is the way we go about it. So once the council has identified a topic, I've said at the moment we're working, for example, on neurotechnologies. We're also got some work on donor conception, information that might be needed for people conceived with donated sperm or eggs or embryos. And so we make sure that we've scoped the project properly so we know the question that we're thinking about. We bring together a group of people with the relevant expertise from different disciplines, different perspectives, different areas, not just academics, though often mostly academics. We then go through a fairly extensive consultation process where we make sure we bring in different perspectives, different opinions on that, and then we identify the core issues that are at stake. And it's only at that point, if you like, in doing this from a bottom-up perspective, that we can really see which are those principles, those values that need to be brought to bear in that particular question. So there isn't a pre-existing set that is going to apply inevitably, universally in every particular situation. So it's from that we can develop those principles, that framework that's going to operate in that particular context. We work up our report and recommendations, and we work with a lot with academics, but we need to bring this to a non-academic audience, and that's critical. Because if you put academics together, they do want to speak their own language. They do want to work their own little corner. And we need to take care, if we're going to reach a wider audience, an audience of practitioners and a public audience, we have to watch out for this kind of thing. This is I'm going to read from a draft of a report that we're working on at the moment. We're going to be publishing it in a few weeks, actually. This is from an early draft. We will consider the formation of biotechnology decisions as the intersection and interaction of three dimensions: the material, the representational, and the orientational. By the material dimension, we mean the dimension of possibility. Material constraints comprise both instance and circumstance, the intrinsic potentiality and constraints of the real, plus the discursively determined conditions of its unfolding. The opening of the... I think you get my meaning. And, we just have to be really careful. If we've got a philosopher, a historian, and a social scientist working together, we can end up with this kind of stuff. So that bit's gone, by the way. We've kind of edited them out a little bit. So we really are insistent that what we're doing is making this work at a level that is comprehensible in a much, much wider context. I'm just going to talk through now, if I may, really quite briefly in each case about some of the reports that we have published over recent years, and just to indicate what the principles are that we start with and how they bear then upon the kind of practical outcomes that we're trying to deal with. And I'm just checking my timing. I think I'm doing okay. We published this report about 5 years ago, 6 years ago, I think. Critical care decisions in neonatal care. The essential point here was about that decision when with extremely premature neonates, 23, 24, 25 weeks, whether to institute intensive care or whether then, having started it, to stop it. The principles, the main principles that were identified as being extremely relevant here were these ones: the value of life, the quality of life, and best interests. I won't open up all of those, but you can kind of see what they're getting at. And the areas in which we reached conclusions were in these. One was about the moral equivalence in this kind of situation of withdrawing as opposed to withholding treatment in the first place. We developed in outline the kind of guidance that would be needed for practitioners on when they might institute intensive care in these cases, based very much on evidence of outcomes, the best evidence that we have of outcomes at certain number of weeks, 23, 24, 25 weeks. And again, the kind of guidance that might be needed to help people through considering what the best interests of a child in those circumstances might be, how they might be considered. And we then recognised also the importance then of communication with families, that these are not simply decisions that are taken by the medical professionals. This is something that needs transparency, it needs ongoing relationship with the families. And then, of course, in that context, the decisions will never be straightforward, ongoing training and support for all of those people. So this is the kind of area that we developed in that case. And I'll come back to it later, but what we then were able to do was to work with the Royal College of Child and Paediatric Health, who did deliver those guidelines based very much on the work that we did. Public health report, this is a very different area of work, and the principles that we were working with there that had to be relevant in this context, obviously going to be very different to the intensive care with extremely premature neonates. This was really working from a more in terms of a political philosophy, if you like, of the role of the state. And we conceived the state as having a stewardship role, that is to say, of having a responsibility to provide the conditions for people to live in good health. And then to ask, well, what is a legitimate intervention by the state for public health reasons? Given the need to respect people's individual consent to any particular intervention, the role of the state in protecting those who are most vulnerable, but also in developing a sense of community. So putting this together as the framework and looking at public health issues such as infectious disease, obesity, smoking, etc., we developed an intervention ladder so that as a practical tool for people considering public health interventions, we offer this as saying the ladder goes through the stages of doing nothing, gathering information, giving information, setting default positions in terms of, for example, what people are offered for school lunches. Then different types of more, if you like, coercive interventions, such as whether to, well, right up to quarantines or legal prohibition, whether it's of drugs, for example. So you've got different levels of intervention, increasingly coercive. And as you go up the ladder, the justification required by the state for coercive interventions is more demanding in terms of what harm it is trying to prevent, how much people are willing to consent to it, how much evidence there is, and what how proportionate that response is to the intervention. So if we look at infectious disease, for example, should we make childhood vaccination compulsory? Well, if we can achieve sufficient coverage for herd immunity with voluntary vaccinations, then we shouldn't have to go to a compulsory vaccination. So that's a stage up the ladder. So this is a practical tool, and applying this in the context of obesity, which might be around, for example, compulsory labelling of food, which now we see the government is starting to move towards. Smoking and alcohol, where we recommended, sorry to say it, increased taxation on alcohol, control of its points of supply, because of the harms. Not because it's a bad thing, but because of the public interest in the harms. So that's the kind of practical tool that we were able to bring in that kind of public health environment. Dementia, we know this is a growing, rapidly growing problem. And again, the cluster of principles that were brought to bear there were around quality of life, interests and autonomy. And this is not just interests or autonomy of the individual suffering from dementia. The interests of their carers, of their families, of the community of people around them are equally part of what one needs to consider. This links into the notion of solidarity that I'll come back to. And then personhood and identity, where we were very insistent that despite the changes that take place, and despite the language that we sometimes use, it's no longer him, that the persistence of personhood and identity is very important as we still value the individual as any other individual. So this was the cluster of principles that then we can apply in the situations, first, for example, in decision-making. The dilemmas in decision-making around the care for people with dementia are daily routines, and they are really terrible. I mentioned some of them earlier around whether to force a parent into a car to take him to the day centre because you know that when he gets there he enjoys it, but he doesn't want to go at the moment. To what extent can you use that kind of force? Can you lock the door when you're popping out for 10 minutes? What do you do about somebody who loves to cook but no longer seems to be safe? There are any number of problems, and the decisions as to how to make those decisions is just really difficult. And we can't give answers to all those questions, but what we talk about is giving people the framework, the tools, the methodology for doing that in a basic level, which is about saying, what are the facts, what values are at stake, and what kind of circumstances would you compare with this? And then enabling carers, professional and informal carers, to work with this kind of approach, but also to give them the training and the support to be able to do it. So this is a kind of approach. This is the kind of stuff that falls out of applying these principles to these kind of situations. I'm going to skip the next. Well, I'd just say this was a difficult area because it's so complex. Personalised healthcare. This was very much in relation to aspects of healthcare that are now being built around digital technologies, online technologies, digital technology, telemedicine, body imaging. They're driven with information technologies, and areas of this are developing in quite interesting ways. We are concerned about issues around privacy, about people's freedom to choose ways of doing things, because online medicines can be cheap, easy to get. You can do it anonymously. These are benefits. We might be concerned about them, but until we start seeing real harms, one must be careful not to over-regulate the kind of things that people can start to do with this kind of technology in support of healthcare. I won't dwell on that, though, because I want to get on to a few other things. One of the most recent reports, and one of your colleagues here was very much involved in this, and she'll have to forgive me if I do this really rapidly and miss out some important stuff. But again, principles, and these do map on sometimes to the other ones of, again, the role of the state in stewardship, altruism as a virtue that we tend to approve of, solidarity, non-payment for human bodily material, etc. And so the public health measures as a responsibility of the state to help reduce the need for organs becomes one of the ways that this plays out. Again, we looked at the notion of an intervention ladder. If we need people to donate parts of their bodies, either when they're alive or when they're dead, if we need people to donate for therapeutic or research purposes, how far can we go in getting them to do that? Can we just ask them, encourage them, apply some kind of moral pressure? Can we pay them? Can we, how far can we go? So if we look at a ladder where we prefer altruism, we prefer the voluntariness of that, we're ready to go that far. Are there some circumstances in which we're prepared to go to induce people who would not otherwise altruistically donate or volunteer themselves? And if we do go to that level, it demands a much stronger ethical justification. An ethical justification where we need to demonstrate that there will be no harm to the donor and that we won't undermine trust in the medical professions, for example. And so we arrive at these kind of conclusions about not paying for organs, being prepared, for example, to meet the funeral costs of people who die and are on the organ donor register, because there's no evident harm that can happen to that donor, but the benefit can accrue, and it, if you like, gives an extra inducement to an altruistic act, which is a tidy solution. But then again, we look at volunteers for medical research, phase 1 volunteers, and our willingness to pay, actually remunerate people for that, which we regarded as acceptable, partly because it's a reasonable trade-off. They're volunteering something that we recognise the value of and that they might not otherwise do. Anyway, that's a complex story, but this was the Human Bodies Report. Now, having surveyed those number of different areas, I ask myself the question, is this just a kind of relativism, where we just say, well, given this situation, we can just pick these principles and they will suit us, they will do the job for us. And it's convenient because we can make that choice. And in another situation, we'll just do something else that is convenient in that. I mean, I don't think that is the case, because I think that we have to, in any particular circumstance, be more robust than simply identifying what is convenient. We need to demonstrate that what we are working with is relevant, show that our argument is well reasoned and that it is persuasive. And I think, I mean, the Council doesn't declare itself with this, but I think one of the things that we're doing is working with this notion of an overlapping consensus, which is, if you like, finding things at a secondary level that we can all sign up to. So if you are, from your in a moral, philosophical standpoint, a Kantian or a utilitarian or a Confucian, you can nevertheless come together and agree that fairness or justice are things that we can work with. So whatever your starting point, we can identify those areas that we can say, these are important things that we can bring to bear on this particular question. So I think that's closer to what we're trying to do when we bring people together from different perspectives and try to find pragmatic solutions. And that's very much where I think it is, that we need to do this in a way that is pragmatic, that it does bring that kind of solid, rational thinking to bear on practical questions with fairly practical outcomes. And what we see then, well, there are two different dimensions to this. One is the extent to which we do have some impact in a practical environment. And I've mentioned already that our recommendations around critical care decision making in extremely premature neonates was picked up by RCPCH, and that is now embodied in sets of guidelines. That's the kind of illustration that we like to see. It shows our impact. And we had another report on the forensic use of bioinformation, where we looked at the police DNA database and the way in which the police will take DNA samples and keep them. Irrespective of whether you are ever charged or convicted, if you are arrested and they take a sample, they would keep it. And we worked this through and recommended that this should no longer be the case. This was an unwarranted intrusion in privacy, and the European Court of Human Rights quoted our report when it forced the UK government to change its policy. That's impact. That's brilliant. And you see that our dementia work, we've been working with policy people and organisations around dementia now for the last couple of years. And so, I mean, there's now the Prime Minister's taken up this, but already there were in place dementia strategies in England, Wales, Scotland and Northern Ireland, and we'd had a lot of communication with the people involved in those. So I'd like to think that we've fed in to the development of those strategies and the practical ways that that feeds out from there. So that's one end of it, though, is the developing the things that have a bearing upon practice. But there's another side that I haven't really touched on that I do want to mention, which is about how this can also, quite apart from helping to inform specific policies and practice, is also just to work in a much broader sense at helping people to think about this stuff. Because I think that we sometimes, whilst we are good at making decisions, we don't necessarily have the language or the understanding of what it is that we're doing. So we do quite a lot of work on disseminating our material more widely through the media. We have a lot of data about the downloads of our reports. We have short versions. We have a 12-page booklet. They're out in the lobby there. We produce these 12-page booklets that are sort of really, I don't want to say simplified, but they're kind of easy to get into versions of the work that we do. We produce a one-page version for MPs. That's about the limit. But we also produce, that's not really, but we also have resources for schools. So from each of our reports now, we develop we kind of pull out of it a set of information or a set of exercises, set of tasks, a set of information sheets and kind of teacher instruction sheets, and we tailor it into parts of the curriculum to enable teachers, mostly in high school, mostly 14 to 19, to work with these, not because we want people to know what we say, but because it will help them to work with their kids to develop ways of their ability to think about this stuff themselves. So we've got both of those things going on. One is to work with and influence and help develop policy and practice, and the other is a much broader way of supporting ethical reasoning more widely. Now, this isn't the end, sorry, just the first stage of conclusions. The next bit's much more important. But if we just pull up at this moment and just note this, which is in the first instance, what I would like to say is that I think we're good at ethics. I've said this a number of times. We, whether it's in healthcare or personally, privately, by and large, I think we're pretty good at it. In a professional environment, we do embed these things into practices and protocols. They obviously need to be maintained and reviewed. But we are increasingly challenged to make explicit what we're doing, why we're doing it, and it's quite right that we're challenged to do that. And it's important that that's done. We do get support from experts, from principles, from frameworks. They help uncover what is the underlying reasoning or the aspects of it that are important. Sometimes when we haven't actually got the language or the understanding of the methodologies involved to do that. But it does not remove the responsibility for making the judgment. It will provide the support, it can provide the framework, but you won't remove that responsibility. For in that situation, there won't be a single simple answer. The use of guidance together with facts, evidence, judgment, rational thought and proportional approaches, that will remain. That's my kind of pause point. Now, I just want to talk about two other things that I think are really important emerging themes that have come out through our work in very recent years. And these are solidarity, which I've mentioned a couple of times already, and trust, which has also been mentioned. Solidarity, I mean, in a way, it acts as a slight counterpoint to that kind of Beecham and Childress cluster of principles, if that is seen, as it often is now, as a representation of a kind of individualistic approach to things. And solidarity is very much about a broader community approach. It's linked to notions sometimes of reciprocity, that we can all gain if we're willing to give and we can maybe receive. Certainly about issues about altruism and trust. We saw this coming through in a number of our reports. The Human Bodies report, a report that we did on biofuels, drew on it very much as well as the Dementia report. And so we commissioned some work. Barbara Pranczak and Elena Books did a nice piece of work examining what solidarity might amount to and how it might play out here. And we can see it as helping to explain, on the one hand, how we relate to other individuals and we respond to their situation. So solidarity within that individual relationship is where we recognise something in common and we offer something without necessarily the need for return, but because we share a common thing. It plays out on an individual level, on an informal group level where, for example, we have patient support groups that are self-generated, and then we operate it at a formal level, and the NHS is the obvious example of this. And we've seen, and I've already shown how we've called on this in our work on dementia, where we want to support individuals with dementia, communities of carers, and to understand that for the future we're providing for across our whole society. And in public health, in human bodies with the donation system, whether it's blood or organs, we believe in pooled donation. This links to trust, which is the second thing, and I'm going to try and do it really rapidly. It does link to trust, which is the second thing that I want to talk about, because we trust our professionals and our systems to carry through these solidaristic thoughts and intentions that we have. And trust, while it's not in a sense an ethical principle in itself, it's a measure of the extent to which we believe that others will act honestly, fairly, and benevolently for others. It's easy to say this, it's hard-earned, easily lost, but you see it lost all the time. The BBC, the police at Hillsborough, the press through phone tapping, politicians through any number of ways. The health professions have got plenty of it. they've got plenty of it, despite what we hear from the jealous politicians and journalists. We've got plenty of it, and I'm going to just give a few examples. I looked up the Care Quality Commission Inpatient Survey 2011, 70,000 patients surveyed. Those, when asked, do you have confidence in your doctors, the number who said no was 3%. The number who don't have confidence in the nurses treating them was 4%. Were you treated with respect and dignity? Those who said no was 3%. The numbers who do not have trust or feel they're receiving respect is very small. The rating of care, did you receive care that was good or better? The number who said yes, 92%. So people have confidence, they have trust. Community Mental Health Survey 2012. Those who had trust and confidence in the health or social care workers was, again, 96% of those who said yes, either always or sometimes. And those who felt they'd been treated with respect and dignity, 87%. I was at a meeting in Berlin. No, there was a different meeting. I was at a meeting at the Barbican. And it was suggested, this was about organ donation, it was suggested that people don't have any faith, they don't have confidence in the way that death is diagnosed through measuring brainstem activity. I just didn't believe this. I looked up the potential donor audit. 1,200 people, this was where there's an audit of those cases where people could become organ donors on their death, but they didn't. Why didn't they? The question, and we've got the answers to that. 1,200 reasons why the families did not give consent when they could have done for organ donation. And some of those include reasons that would suggest that they have no confidence, they don't trust what's happening when the diagnosis of death takes place. The number of families who were concerned about organ allocation, 1. Those where patient treatment may have been limited to facilitate organ donation, 1. Those where the family had difficulty understanding or accepting neurological testing, 7. That's out of 1,200. And so there is a good deal of trust. And there are plenty of ways in which we can see that happening. So there's other stuff. I'm going to have to cut it short. It does take me rapidly through. Just one more book that I found on Amazon while I was looking up this. And given that there are quite a lot of junior doctors, trust me, I'm a junior doctor. Ethics of Banking, $139. Trust me, I'm a junior doctor, 1 penny. I don't know what that tells you. Anyway, this is it. There is a lot of trust. I believe that, and I think it is justified because we are good at ethics. We are challenged. We are challenged in that, and it's quite right that we are challenged in that. And it's quite right that we're challenged to be transparent. We're working in a public space, and we must keep working in that public space, working with the public, with the people who we're interacting with. And there is a role, of course, for bodies like mine, for advisors like yours, for committees and other support works, because that's how we open up these questions. We identify what the principles are, we identify what it is that we're doing, and we get support for our practice. And if we do it transparently, it will continue to reinforce trust. The reason that the BBC and the police and the journalists got into trouble, because they didn't recognise the issue. They didn't consult the right people, and they didn't do it all transparently. So if we can keep working with this, opening up the questions, challenging ourselves with them, discussing them with the people we need to, doing it openly, we get into a virtuous circle. And I think we do it well, and I think we should just keep going with it. Thank you.